Thank you so much for joining us this afternoon. Appreciate your joining this event. Good afternoon. I'm Dr. Maurizio Fava. I'm the Chief of Psychiatry at Massachusetts General Hospital. And on behalf of the Department of Psychiatry, I'm pleased to welcome you to the second session of the MGH Leadership Council for Psychiatry Visiting Day series. As many of you know, the Leadership Council's annual Visiting Day takes place every June. It's kind of a tradition now for years we've been doing this. But this year, because of COVID-19, it has gone virtual and is now a series of 4 sessions featuring our outstanding faculty. Thank you to the Council for your continued support. I know many of you are here today along with other friends of the department, and we're truly grateful for your presence. The topic of today's seminar is innovations in research. 4 faculty, outstanding faculty in our department will talk with us today about their exciting and groundbreaking research. You know that I'm a big believer in innovation, that one of the mottos, that it's not my motto, but that I really embrace is that the best way of predicting the future is to make it. And that requires innovation. Also joining us today is Connie Sullivan, who will talk about her daughter who has autism spectrum disorder and now has a new and effective treatment researched here at Mass General, treatment that has improved her daughter's life. And so we'll hear from her. And it's a great privilege to have her with us. Later in the program, Dr. Lee Cohen, who's Associate Chief of Psychiatry for Philanthropy and Departmental Communications, will lead a question and answer session. We invite your questions and look forward to a lively and informative seminar. We'll try to make it as interactive as possible with the Q&A at the end. So I'd like first to introduce our extraordinary faculty. Dr. Roy Perlis, Associate Chief of Research in the Department of Psychiatry, Director of the Center for Quantitative Health and Professor of Psychiatry at Harvard Medical School. Dr. Gagan Joshi, Director of the Autism Spectrum Disorder Program, Medical Director of the Bressler Clinical Research Program, and Associate Professor of Psychiatry at Harvard Medical School. Dr. Paola Pedrelli, Director of Dual Diagnosis Studies at the Depression Clinical Research Program and an Associate Psychologist at Mass General, and Assistant Professor, soon to be Associate, hopefully, at Harvard Medical School. And Dr. Josh Roffman, Co-Director of the Mass General Neuroscience Initiative and the MGH Division of Psychiatric Neuroimaging, and Associate Professor of Psychiatry at Harvard Medical School. So let me start with Roy. Our first speaker is Dr. Perlis, whose lab has made key contributions to understanding the biological basis of psychiatric diseases. In his research focus, Roy is very eclectic and kind of span from big data to basic science to clinical. It's identifying predictors of treatment response in brain disease, using these biomarkers to develop novel treatments. He's also investigated patient-derived cellular models and the application of machine learning to large clinical databases. So Roy, could you talk to us about your current research?
Thanks, Maurizio. And again, thanks to everyone who's tuning in today. We're grateful that you're interested in the work that we're doing. Last year, I had the privilege about this time of being a keynote speaker at our visiting day. And I talked to y'all then about our work in using cellular models, stem cell models, to try to understand brain diseases. And so one area of research that I'm very involved in is, can we take cells from people, use those cells to model brain cells and what's going on in the brain, and try to use those to develop new therapeutics or new markers of risk. But at the risk of stating the obvious, it's been a little hard to work in the lab over the last few months. So about 3+ months ago, we had just started some really large experiments when it became clear that the wet lab where we do all this work had to close. Our techs couldn't get back and forth safely. Some of my scientists were busy working at the main hospital testing for COVID. There was a possibility that several of us were also going to be working on the clinical wards. So my wet lab came to a screeching halt. But fortunately, as Maurizio said, I also spend a lot of my time working with big data sets and trying to understand other ways that we might make predictions about treatments. So before I get into the specifics of what we might call precision medicine, I felt like in the interest of just showing you something interesting about COVID that you might not have seen, I wanted to very quickly show you some maps of the United States. And these are maps that instead of showing you things about how many COVID cases or hospitalizations, this hits a little closer to home. So let me just pull this up for a minute and show you. So you might call our current situation the United States of anxiety. This is actually data from a survey that we're doing every 2 weeks in 20,000 people across the United States. And the survey asks about political affiliation, and it asks about beliefs about COVID, and it asks people if they're wearing masks. But my piece of the survey also asks about things like depression and anxiety. And one of the truly remarkable things that we are seeing, which won't come as a surprise to any of you, but is sort of notable just to see, on average, if you survey people about depression, anywhere between 5 and 8% of people will endorse depressive symptoms at any given time. At the moment in the United States, between 25 and 35% of people will endorse symptoms of moderate to severe depression. And that's what this map on the left side is showing. So it's just showing you state by state what proportion of people endorse enough symptoms of depression that at least in a primary care setting, someone would say they had moderate depression that needed to be treated. So that's sort of the backdrop for this conversation, that I think while we're going to talk about precision medicine today, we need to be aware that all of our efforts to come up with better treatments for depression, for anxiety, for other mood disorders are now compounded by this massive external source of stress. And so some of the work you're going to hear about today is only becoming more important as we realize that this initial coronavirus peak is only part of the challenge. It's not just the infection, it's the consequences of the quarantine and so forth. So with that in mind, I'm going to stop sharing and I'm going to switch gears a little bit and talk briefly about what else we have been doing. So there's been a lot of enthusiasm in psychiatry for what you might call precision medicine or precision psychiatry. And the basic concept here is that we'd like to be able to do a better job matching treatments to patients. And of course, there's been lots of hype about artificial intelligence, what we used to call machine learning back in the dark ages. And the idea is if we just train the computer properly, we will be able to make better predictions about treatment. We'll be able to better match interventions to patients. Now, this is a wonderful concept, but I want to set some expectations here. As someone who's worked in this area for more than 2 decades, we can do really amazing things with things like images of chest x-rays or EKGs. We're still struggling to apply these technologies in psychiatry. And so I think when you hear about AI and precision medicine psychiatry, it's important to take it with a grain of salt or several. So for example, there's been tons of enthusiasm about using health records for suicide prediction. Can you look at someone's health record and say they are likely to make a suicide attempt? We would love to be able to do this. And in fact, our lab did some early work in this area, and then we stopped. And the reason that we've stopped is we realized that most of the time, what we're finding is that the predictors of suicide are things we already know about: mood disorders, substance abuse. And so what we can do is identify people who are at elevated risk, but we really struggle to know who's going to make an attempt and who's not. It's very much like my son is a weather aficionado, and he can tell me based on the forecast that there are going to be thunderstorms in the Boston area, but he can't tell me where lightning is going to strike. And so I want to be clear that while AI can do a lot of impressive things for us, and it can probably tell us in the case of suicide who on average is at greater risk than who else, we have to be really cautious in the claims we make, because at least right now, even when we say based on health records, this person is high risk, fortunately, a very small proportion of those people will actually go on to make a suicide attempt, okay? Having said that, though, there are ways that we think we can use artificial intelligence to take advantage of electronic health records to do better in treating things like depression. So my own group has been focused on using health records, for example, to find the optimal antidepressant to treat someone. And in fact, we make 3 different sets of predictions. One of them might be a little counterintuitive, but probably the most useful. Who's going to get an antidepressant prescription and never come back? Like, this is a missed opportunity, especially in primary care. Someone finally got up the courage to come talk to their PCP, got a prescription, and then never filled it, or never even came back again. So that's one set of predictions we make. Who's going to drop out of care? Because those are people where we want to make sure we follow up closely. We have a nurse make a phone call to them. The doctor calls them sooner. We do things to encourage them to be consistent in treatment. Another prediction we make is who starts an antidepressant and then gets re-diagnosed with bipolar disorder. This doesn't happen very often, between 2 and 5% in our health system, but it can be potentially catastrophic if we precipitate a manic or hypomanic episode. So we're actually pretty good now at predicting when someone starts an antidepressant who requires additional vigilance. And then finally, we're predicting who's going to get on a stable antidepressant regimen. These are all papers now that are in press in various journals. One of the interesting things that we have learned along the way is AI has a bunch of problems in precision medicine that we need to help clinicians overcome. One of them is the black box problem. When you go see your doctor, you don't want your doctor to say, I'm going to put you on Prozac because the computer says I should. At a minimum, you want to understand why the doc is making that recommendation, right? And by the same token, docs don't like black boxes either. We don't necessarily feel comfortable just doing what the computer tells us to. So one area where we're working actively is in how do we make predictions that are more interpretable, more transparent, rather than just black boxes. The other thing we're doing is studying cockpits, like airplane cockpits, because it turns out that a major contributor to some very prominent air disasters, like with the 737 MAX and the Air France crash, is when artificial intelligence or dashboard indicators give you wrong information. And so we've been doing work recently because it turns out that while AI often does pretty well, when it fails, it tends to fail catastrophically. And what we've shown is that clinicians can be misled, docs can be misled very easily when artificial intelligence goes wrong. So we're working on solutions for that. Last but not least, we're working on ways of integrating the machine learning models we're building, the AI models we're building to make better predictions about which antidepressant to use with the cellular models that we're building in the lab. And I'm excited to report our wet lab is back open. We made our first neurons from neonatal cord blood this past week so that we can start making predictions ideally at birth about someone's longitudinal trajectory, at least in terms of brain development. And so the other big project in our lab, and the thing I'm maybe most excited about, is how do we take what we can get from electronic health records and integrate it with genetics and with cellular data, really to get to the goal of more personalized treatment. So again, thanks so much for your interest, and thanks for joining us today.
Well, thank you so much, Roy. Fantastic work. To move on. So one thing, you can use the chat function to start asking questions from terrific faculty. So use the chat and write questions, and then Dr. Lee Cohen at the end will moderate that discussion. So you can start doing that and entering your questions. So let me move on to our next speaker, Dr. Gagan Joshi. He's a leading researcher and clinician autism spectrum disorder, or ASD. And he's investigating the potential of neuroimaging to identify neuromarkers in ASD that offer treatment options and early diagnosis. Joshi, you've been researching the effects of memantine, a glutamate modulating agent, a drug that is approved for dementia, and nobody had ever thought before you to try it in youth with high functioning autism. Could you talk to us about your research and what you have found?
Thank you, Maurizio, and thank you everybody for joining us. You asked the right question, Maurizio. How did we even think about a memantine to be used in a population which is definitely not demented? And how could that be useful? So let me take you through a little bit of a journey. How did we come to this point of an exciting finding? We have a true biological marker which helped us with this decision making. So I'm gonna share a screen with you, if that's okay. And I think, here we go. So can everybody see the screen, especially our group here? Are you able to see the screen? I'm saying sharing. Yes, can you see it? So this journey sort of starts roughly 12 years ago when we started sort of profiling a high functioning spectrum individuals, and with the help of a lot of families I treat, and one of them you'll be hearing in a minute from, and with the help of my colleagues and co-researchers, we started sort of profiling this population. How do they look clinically? Because this is a population which has never been understood clinically, or to say the least, in their brain functioning. And we started profiling them and looking into their brain for any abnormality associated with their clinical presentation. The first thing we found in the beginning, this is 8 years ago, is that in a very particular area of the brain, which is highly relevant for autism spectrum disorder, because it processes social functioning and also emotional functioning of folks, we found extremely high levels of a neurochemical called glutamate, which is highly essential for the development of the brain. Now, having found this high levels of, abnormally high levels of glutamate in the brain in folks who had autism spectrum disorder, the logical question came to our mind that should we look for a medication treatment which can lower the levels of glutamate? Pretty much like if you are running high sugars, you would like to use medication which can lower down the sugars and see if it also improves their social and emotional functioning. What we interestingly found in that population, that as Roy was saying, that we have to individualize treatment, that not every autism person was suffering from high glutamate. It was more than half, roughly 60% of those folks had high glutamate activity. So in a way, we identified a subtype of autism in high functioning autism, which had high glutamate activity. Then we sort of picked up this medication memantine because it's a glutamate modulating agent. It brings down glutamate, supposedly brings down glutamate activity in the brain and helps. And then even in dementia, where people are trying to help folks with Alzheimer's disease, it not only probably improves their cognitive functioning, it also preserves their social relatedness. And the families oftentimes are looking for help with their elderlies where they don't lose that social relatedness. So there was some signal there too that this could be helped with the social difficulties folks with autism face. So we did this memantine study. This is a trial of memantine in youth with high functioning spectrum, and individuals with high functioning spectrum in their lifetime, they suffer from the impairments most in their teenage years. So we took a teenage population, we treated them with memantine, and we also took their brain glutamate levels before treatment of memantine and after treatment of memantine. What we found, strikingly, that the folks who had high glutamate activity in their brain, those are the ones, all the folks who responded on memantine were having high glutamate activity in the brain to begin with. The ones who did not have high glutamate activity, in reality, they did worse than expected on memantine. So here it seems like that we have a neural marker, which if we can tap into before offering the treatment with memantine, we showed that there is a high, very high chance that if the glutamate is running high in their brains, they will respond to memantine. And what does response mean like in this population? The response was that they were more socially aware, more socially curious, more expressive, a lot more about their feelings. They could understand other person's point of view, showed more flexibility, and also at the same time, their quality of life improved with their family because their relatedness improved with their family members. It was very well tolerated. And what we are looking forward to now is that to validate this neural marker, this high glutamate activity, to see not only that if we can assess this levels of glutamate in the brain, we can then choose whether they will be a good responder to memantine or not, or to other glutamate modulating agents. So this is a target which is guiding us to pick up other glutamate modulators. And at the same time, because in this population, the diagnosis is often late, and you'll hear Connie talk about that the diagnosis in high functioning spectrum is very delayed. If we could take the population at high risk and do their glutamate levels earlier in age to see if they could be at risk for autism, behavioral impairments in near future. So this is where we stand, and we are very excited about it. I truly, truly want to thank all the families I come in contact with clinically, and all the families who participated in this research process over 10 years to bring us to this point to say that we truly have a neural marker for a response, to say that least, for the treatment of autism spectrum disorder.
Well, thank you so much, Joshi. Terrific work. Why has it been a challenge to find effective treatments for ASD? This is a relatively common condition. So many families are affected. Why is it hard to find treatments?
Maurizio, I think one challenge, which is obvious now, that if we do not have a way to look at this very heterogeneous population. I mean, autism spectrum extends from people who are nonverbal, don't make eye contact, don't have language, and their intellectual ability is impaired, to folks who are intellectually capable, very logical, very verbose, make good eye contact, and want social interaction. So the spectrum of this disorder is so heterogeneous that if we are not mindful to be very selective in picking the population who we are testing, the responses, for example, in this study too, if I had not been mindful about this high glutamate versus not high glutamate, then the normal glutamate did not respond well. Together, the whole pool would have shown me that it is not as effective as excited I'm feeling once I know that the high glutamate group responds. That is one reason. The other reason is that this high functioning population is also clinically not very well understood. Most of the research done in autism is done with the measures which are for lower functioning population and don't tap into the higher order of cognitive deficits which the high functioning population suffers from. So they don't assess the severity of these higher cognitive deficits, nor do they know how to assess the outcome on these treatments. So most of the research done is in a very varied heterogeneous population of autism, and that is probably the other reason why the research has often failed.
Well, thank you so much, Joshi. Now I'd like to introduce you Connie Sullivan, whose daughter Christine is a patient of Joshi's. Thank you so much, Connie, for participating in this event, telling us your story today, and we really appreciate your being here. Connie?
Thank you, Dr. Fava. When my beautiful daughter Christine was 6 years old, she had already been multiply diagnosed, misdiagnosed, treated with multiple medications to which she had high sensitivities, adverse reactions on the lowest possible doses, and at one point ended up in inner city Trenton crisis unit at a midnight, where 3 nurses sat on her to draw blood. We were referred for a second opinion to Dr. Joshi. My takeaway from that was 3 points. Number 1, you're not at fault. None of you are at fault. Number 2, go home, You have a computer, research PDD-NOS, which he explained was the umbrella for autism. Number 3, get Christine an evaluation as soon as you can. I'm highly confident you'll find she has autism spectrum disorder. We did the evaluations. We confirmed Dr. Joshi's suspicions. Christine's diagnosis today is generalized anxiety, depression, and autism spectrum disorder. Christine still suffered through years of trying to find the right medication. She's chemically very sensitive. We continue to have adverse reactions. Meanwhile, schools failed her. They didn't understand the autism diagnosis because she didn't flap her hands. She didn't bang her head. She was verbal and she did make eye contact. So by the time we were 18, Christine had fallen away from society, refused school, refused to get out of bed, had become self-injurious, suicidal, had 3 hospitalizations, one of which was a 6-month continuous crisis hospitalization. Our turning point was this miraculous memantine. When Dr. Joshi found Christine capable of trying the memantine, he explained it as previously the brand name Namenda XR, and a light bulb went off. I remember one of our many treks between Boston and New Jersey to see Dr. Joshi and leaving once with 2 paper prescriptions in hand. One for an anxiety med, one that was scrawled, "Watch for Namenda." When it was Christine's turn, I felt a shiver of joy and hope run through me, but I was cautiously optimistic. I was foolish. This man's been with us every single step of the way since Christine was 6 and never gave up. Why now? So we started the memantine at a low dose of 7 milligrams, and within a week, Christine was in her residential placement, getting out of bed, getting dressed, getting to class, participating, taking showers, brushing her teeth, caring what her hair looked like. She had goals. She started to advocate for herself. She ended up passing her MCAS, a girl who had stopped school in 2nd grade. So Christine now is 21. I'm happy to say she's graduating high school this month with a diploma, not just a certificate of completion. She's just completed her 4th college course with a GPA of 3.7. She wants to enroll and get a 4-year degree, and she is studying to get her driver's permit. You may see congratulations balloons behind me. I'm a little proud, and it's a bragging moment. We're the lucky ones. We're fortunate. My family and my friends are in awe. They're in disbelief that Christine has gone from there to here. What happened? MGH, Joshi, memantine. Probably over 40 medications through the years, but memantine was the one that made the difference. We continued to titrate up on the memantine and started to be able to titrate down on heavy hitter mood stabilizers, things that saved her life but sedated her and had really terrible adverse side effects. So we've never been alone. We were in awe too, but never in disbelief because we've never been alone. I remember a time when Dr. Joshi returned a phone call when Christine was in crisis in Princeton, and he called from the middle of a harbor from someone's cell phone. There was a time when Christine was sent to the ER with hives, and Dr. Joshi immediately sourced out it was an inactive ingredient from a generic drug that she had been put on, and insurance was called to task by Dr. Joshi, never to be repeated. We've watched kids in all the 5 programs that have failed Christine, except for the most recent, be in prone restraints and seclusion because not only can they not afford memantine and Joshi and Mass General, they can't afford breakfast. So we are the privileged ones. We are the lucky ones. Our gratitude to Mass General and Dr. Joshi, it puts a Hallmark Channel to shame. So we are the fortunate ones. I'd like to see a way we can get this to everybody else so it's not just the privileged few who get to experience this. Thank you.
Thank you so much, Connie. That I think that your story reminds us of the critical aspect of us clinicians at Mass General, which is we never give up and we always try to find the solution for our patients. So, Gagan, what led you to memantine in the case of Connie's daughter? What was the intuition that you had?
First, thank you, Connie, for sharing your personal story. If you permit me to say our story, because I've known Christine, I met her when she was 6 and known her for 15 years. And I think we both have grown together In fact, I've grown poor in my vision and probably lost my hair too. But she has definitely grown emotionally and socially, and I'm so proud of her. Uh, I but the point is that we, even before I went for the trial, we had the results from my imaging and saw the glutamate was high. And I just took a shot in the blind. I said, why not I just give it a try and see if it works for her? We knew that memantine was helpful with the moderate ADHD, but beyond that, we had no idea what it would do. So it was one of those acts of desperation when you are trying different medication. And this is where I feel like that we wish that clinically we could reach a point where we don't keep trying and losing precious time with families in the most critical developmental years. And we are lucky, and Christine is lucky that it did help. I'm so excited to say this, that 21 years of old, such a mature girl, gone through college now, and I have titrated the medications down, which tells us that not only that the behavioral interventions help, in this, at a critical time, if you don't treat them with medication, they can't engage in behavioral interventions, and they can totally be derailed in their life and take a different route. My wife, who was an inpatient clinician at Franciscan, and Connie, if you don't mind telling that, she one time in rage and out of sheer fear, she pulled a wash basin out of the sink, and she's a big girl, and if you are big, people get intimidated pretty quickly. So she has made a long journey from there to now where she is. Um, I I I hope that we can disseminate this knowledge. We can validate this this findings, establish this as a regular treatment, and offer this service to many other folks. I mean, one last thing I would say: talk about autism. Lee was saying it's such a beautiful weather out there, but unfortunately, Christine will be very scared to go out there because she has sensory dysregulation, and if she hears a bee sound, which only she can hear, nobody else, she gets very agitated. She can't tolerate that. So these little traits of autism can create such level of impairments that it can really be very demoralizing and impairing in their functioning. So they are devoid of many of these pleasures because of these issues they struggle with. So struggles are still there, but she has developed enough internal strength to handle them and manage them. Thank you, Connie.
Well, thank you so much, Connie and Joshi. Joshi, you may want to stop sharing your screen so that the next speaker can do it. But
I did that.
I just want to remind our audience.
I tried to do that. My
Okay.
screen
Just have to go to the top of the Zoom and say stop sharing. I just want to remind all of you, if you have questions, use the chat function and ask questions to our speakers. We'll have the Q&A at the end. Our next speaker is Paola Pedrelli. Dr. Pedrelli's research has focused on improving the care of patients with depression, optimizing treatments for depression when it occurs along or occurring with substance abuse, whether it's marijuana or alcohol or other drugs. But Paola has really been a pioneer in this area. Paola, I know you're interested in using technology to help people with depression. Could you talk to us about your research on wristband and smartphone sensors and how those sensors could be used to assess severity of depression and other things?
Thank you so much, Maurizio, for having me and to just give me the opportunity to share my research. So I have a lot of different interests, and today I'm going to focus a little bit more on depression. I'm not going to talk about substance misuse so much, even though that's definitely one of my passion as well. But before I dive in on the sensor, I'm always a big fan of giving context and really just giving the reason why I'm so passionate about what I'm doing. So definitely, like, depression has been the focus of my research for the past 15, 20 years. But something that I've been focusing more lately is really to identify ways that we can improve the way we deliver treatment. And so basically, just how can we provide better treatment? Because we have a lot of medication, but not everybody gets adequate treatment. And what does that mean? So we know that despite we have many evidence-based treatment for depression, only half of the people with this disease in the United States actually get treated. And only 25% of those with depression the past year receive adequate treatment. So that means, like Roy also mentioned this, like they might go to the doctor, they might be prescribed Zoloft or Prozac, and then they might stop taking the medication within a few weeks because of side effects, maybe it doesn't work. Or alternatively, they might stop the medication within a few weeks, and we know that they have to stay on the medication for 4 to 6 weeks. But so what I've been thinking about, like what is happening? Why is this happening? So we also know that most of the patient with depression at this moment are managed in primary care setting. And we also know that, unfortunately, PCP or primary care settings are very limited resources to monitor patients. But monitor is really important because medications always need to be adapted and need to be adjusted. So as I was saying, like if there's not this monitoring, like the patient might go to the doctor, stop medication and not reach back, or they might go to the doctor, reach remission and relapse and not necessarily go back to the PCP. And we know that at this point we have this delay in the treatment in really getting the optimal care with very significant problem, of course, and consequences. And these are not uncommon scenarios. We know that only 30% of individuals respond to the first treatment trial. And we sometimes have to go to 3, 4 sequential trial before people actually remit, because sometimes like we have a lot of medication, but we don't know what's going to work for whom. And this is actually all the work that, some of the work that Roy is doing with precision medicine. So the current system is really putting the majority of the responsibility for receiving optimal care and adequate care on the patient. It's really the patient that needs to reach out to the doctor, needs to go back, tell them they respond, they're not responding. And this is not efficient and not possible at this time because of resources. Some patients, they don't have financial means and they don't go back, or they might have stigma, or they might don't think that they can get better. So what I've been thinking about and been focusing more lately is really how do we facilitate this monitoring and how do we make it cost effective? So something that we can do is really using technology. And so at this point, we think that monitoring can be potentially conducted with the use of technology and artificial intelligence. And again, Roy has already mentioned a little bit about how exciting is artificial intelligence with some caveat. So something that it's important to realize is that in the past decade, there's been this quiet revolution in psychiatry where we've been able to rely on technology to finally being able to objectively assess depression. So in the past, we've always had to rely on clinical interview and subjective report. And while we're not quite there yet, I understand that Roy was saying that as well, I think we're getting really close to be able to operationalize the phenotype of depression and be able to measure it. But so what does this mean? Let me just give me 1 second and be more specific with a slide. Okay. Okay, so what do I mean by being able to objectively, sorry about this, so objectively measure depression? So many people might be familiar with the symptoms of depression. So when we think about depression, we think about low mood, psychomotor retardation, sleep problem, and problem with concentration and fatigue. So these symptoms can actually manifest behaviorally, and this is what we actually ask about when we do a clinical interview. So people might not move a lot from their house, or they might sleep poorly, or they might stop running or doing activities. And so now we have a way to measure all these phenotypes accurately, or like mostly accurately, with sensors that can be either worn, like think about the Apple Watch, or we can actually have sensor in mobile phones. So for example, we know how whether people move a lot from their house to the office or go running with looking at their GPS, or we can use accelerometers embedded in sensors or in wristbands or in wearable. We know whether they move slowly or they move at a normal rate, or we can actually measure also vocal speed, like vocal features. And so let me actually go back to. So what okay, sorry about this. All right. So at this point, like, what I've been focusing on sensors research, and what we've been doing in the past few years is to study the development of model that can passively assess depression, leveraging all this data that we are able to acquire through sensors embedded in phones or wearable. And so we finished a study last year, and then we were recently awarded an MGH funding to do a larger study still with sensor. And again, the next step is going to be develop platforms that I will be able to record passively the activity of the patient, and then develop alarm system, so then either the patient or the doctor know when it's time to go back to the doctor and change medication or maybe increase medication. And so this is really like my focus at this point.
Great. So Paola, thank you so much. The question that I have for you is, it's great, all these sensors and the use of biomarkers, but I know you're also very interested in treatments and improving access to treatment. And about 50% of the patients who suffer from depression in the United States are not treated adequately. So how can your research lead to more people receiving treatment?
Thank you. Yes, that's actually definitely one of my passions, like to develop treatment. So if we think about currently, treatment are focused on either prescribing medication or like face-to-face treatment with a therapist like me. So, but a lot of people, like a number of barriers include stigma, include not really want to disclose to a therapist, not being able to access a therapist because they're just not around, so, or a therapist or a psychiatrist. So I think that if we have ways to identify time when people need an intervention, that will be very efficient. So there's a lot of ad-based treatment that is being developed at this point, but we have a very significant problem with engagement because people engage a couple times, it doesn't work, and so they just go back to do nothing. But I think that if we develop this platform that can monitor patient symptoms over time, then we can also develop this intervention that's called just-in-time adaptive intervention, and send a text and say, hey, Mr. White, like, do you haven't done your usual number of steps, like you need to increase your step, or you haven't called your best friend in a little while, like you need to call your friends. And so we can identify which features are very critical for a specific patient and also develop intervention that way. So I think it's going to be very important to continue that type of studies.
Terrific. So I just want to remind people, please use the chat function on the Zoom to ask questions to our panelists. I think it's a great opportunity to get all these experts to answer your questions. And Cohen is going to moderate the Q&A session. So let me move to our fourth and final speaker, who's Dr. Josh Roffman. His pioneering studies showed the neuroprotective effects of folic acid in both schizophrenia and normal brain development. He leads the Brain Health Begins Before Birth, or the B4 project, a hospital-wide collaboration to research prenatal early protective factors that prevent serious mental health risk in children and teens. So Josh, can you discuss your Brain Health Before Birth project? I know you're investigating the possibility that COVID-19 may put children born during the pandemic at increased risk for neuropsychiatric illness. Can you tell us about it?
Thanks, Maurizio, and thanks to all of you for spending some time with us this afternoon and for all of the wonderful things that you do for our department and for our patients. So brain health begins before birth, or B4 as we call it for short. is an ambitious hospital-wide initiative that was launched within the last year, which is geared squarely toward prevention of psychiatric illness. Why would prevention be important? Well, one thing that is critical to keep in mind is that psychiatric illness and the burden of psychiatric illness is really felt most acutely by young people. Of those who develop any psychiatric illness over the course of their lives, 3/4 of them will develop serious symptoms by their early 20s. And so it's no surprise that the total burden of psychiatric illness on every measure of illness and productivity and burden to society, to individuals and families, is tremendous, because these disorders are often with our patients for life. So at the same time, we don't really have much that we can do at this point to prevent the onset of these illnesses. And obviously that is an approach that could, if it were effective, have enormous public health impact. The model that I like, and in training in medicine a bit before psychiatry, is in cardiology, where you have non-modifiable factors like genetics and sex and age that contribute to cardiovascular risk. But there are also modifiable factors, diet, exercise, quitting smoking, that have tremendous effects on reducing someone's risk of having cardiovascular illness. But in psychiatry, most, if not all, of our risk factors are of the non-modifiable sort. So in order to approach prevention, we first need to understand how we can modify the course of a disease in a way that will reduce risk and lead to better outcomes. Now, in order to do that, of course, we need to start before the disease begins. And how early do we need to start? Well, the answer may be a bit surprising because it's earlier than you might imagine. In fact, there have been numerous prospective large studies that have taken place over the last decades that have clearly established a relationship between certain exposures during prenatal life and risk for serious mental illness that begins in childhood or even begins as late as early adulthood. Things like obstetrical complications, preeclampsia, maternal infection, stress during pregnancy, several other important psychosocial factors. All of these have been tied to increased risk later on for depression, anxiety, schizophrenia, autism, and other serious mental illnesses. We just completed a study involving data from almost 10,000 children aged 9 and 10, and we started to look at what the cumulative effects were of some of these prenatal exposures, and saw that while children who had no such exposures only had about a 4% risk of clinically significant psychiatric symptoms by age 9 to 10, those that had 4 or more such factors, and these are not uncommon exposures, they had a 28% risk of clinically significant symptoms at age 9 to 10. That's a 7-fold increase. And again, these factors are non-modifiable. So what we are hoping to do with the B4 initiative is to find modifiable factors. We want to discover them, we want to develop them, and we want to implement them. And we can do all of those things at Mass General. I'll try to share my screen just to show one schematic to give you a sense of how this should work. Hopefully you should be able to see this. The idea is to start a longitudinal cohort that begins in pregnancy, where we are following women early in their pregnancy, following their environment very closely, taking biological specimens during pregnancy at childbirth, and then of course following the children longitudinally to look at neurodevelopmental outcomes. And then we put that data together, not just to say what happened during pregnancy to increase risk, but rather what happened during pregnancy to decrease risk. Let's say in an individual who had increased genetic loading for a given psychiatric disorder, but didn't end up developing that disorder. What happened? So we pull these data together, we take it back into the lab, we exploit the data using cell and molecular biology. We try to develop new interventions, lifestyle interventions to begin with, because it's the lowest hanging fruit. And then we bring them back and we implement them. And that's why it's not just an observational birth cohort, it's a learning birth cohort. So Maurizio mentioned COVID-19, and I can tell you, let me just stop my share, that while COVID-19 has unfortunately caused numerous programs to pause their research, our research has accelerated. And the reason for that is something that I think Dr. Perlis set up very nicely in the slide that he showed. So there are 140 million live births worldwide every year. We know that COVID is going to infect women during some of those pregnancies. We don't know how many yet. We don't yet know whether COVID is actually passed through the placenta from the mother to the child. However, we do know that the virus that causes COVID infects the placenta. We know that the virus induces an inflammatory state, and some of those mediators of the inflammatory state cross the placenta and have been tied in other studies to poor neurodevelopmental outcomes. But even for women who are not infected, think about the level of stress and depression and other mental health problems right now that are unprecedented, that again may increase the level of risk for the offspring. So of course we need to study this and understand it, but even more importantly, we see this in a strange kind of counterintuitive way as an opportunity, because potentially there will be more at-risk pregnancies and more children who are exposed. We again have the opportunity to follow those children who were exposed but who do well, and to understand why they're doing well. So using the B4 framework, we're taking the same approach to try and understand what these exposures may be that confer protection during this difficult time, so that we can take that and then try to implement interventions that not just are important during the COVID era, but later on as well. So that's a brief version of what we're looking to do over the next few years. It's going to be a long-term project for sure, but we're in a good place right now in terms of where we're starting, and hope that this will be high impact work.
Thank you so much, Josh. Terrific work. I'm now going to ask my friend and colleague, Lee Cohen, who's professor of psychiatry, world expert in women's mental health, and associate chief for philanthropy and departmental communications, to moderate the Q&A. Just with our panelists, I just want to remind you, please use the chat function. If you have a question for our panelists, this is a great opportunity to ask questions. Lee.
Terrific. Maurizio, thanks so much. I also want to thank the people for taking time out of their day to sign on to listen to these. It's very exciting for me, because I know that each of these individuals could go on for a long time, could each take an hour to talk about their work. And so we've seen sort of a capsule of the science in which they're involved. And it looks like Dr. Perlis just fell into his garden, but I'm going to ask him because there's a question for Dr. Perlis. Dr. Perlis, you don't seem optimistic about being able to match patients with medications. My psychiatrist even did a blood test to see what I would respond to. Is prescribing random? You're muted, Roy.
So I've spent the last 2 decades trying to personalize antidepressant treatment, including with genetics. And I will tell you that on the genetic side, we just published a study actually with Dr. Fava, big randomized trial where genetic testing did not improve our treatment outcomes. Now, I do think genetic testing in some circumstances can still be helpful, so that's not the final word. What I do think, though, is we can use electronic health records to actually make quite good predictions about which antidepressants are likely to be more or less helpful. So I'm actually still very hopeful. I just think that genetics itself hasn't helped us as much as we hoped.
Thanks, Roy. And also I want to encourage people, first of all, we have such a terrific number of attendees this afternoon. Please feel free to send in your questions, and I have some that have already been sent in, and we'll take some more on the fly. And so there's Joshi, a question for you. My son had autism spectrum disorder, and ADHD. He was treated with medicines. The ADD is better, but not the autism spectrum symptoms, not so much. And so could you speak a little bit about memantine and ADHD and sort of the interface between ADHD and autism spectrum disorder?
So thank you, Lee, for the question. So it's a very relevant question, actually. In the high functioning autism, roughly 80% of the folks who come to our clinic have ADHDs. It's a very common comorbid condition. And interestingly, the DSM just included in the new version that ADHD folks can have autism and autism folks can have ADHD. And in that high function, I'm not sure whether this child is high functioning or not, but if the child is high functioning, ADHD can be very damning. So I'm glad that kid is getting the treatment for ADHD, and it's hopefully effective for ADHD. Now, ADHD, improving that also improves socialization a little bit, because ADHD itself has its bearing on the social functioning, but it may not improve the autism behaviors. It may make them more attentive to engage in autism specific treatments, but it probably will not have a direct effect on the autism deficit, the social deficit they suffer from. We are right now studying the neural interface of ADHD and ASD, because there is this mythical understanding with the low functioning autism is that the ADHD medications worsen autism and that they are less tolerated and the response is poor. And based on that, with MIT, we are looking into the neural correlates of ADHD and ASD, and we're trying to see if the ADHD neural picture is the same, what we see typically in the population. Do ASD people have the same ADHD profile, neural picture as the typicals have? So, I mean, that is all in the future. So there is a lot of overlap genetically, shared genetic aberrations between ADHD and ASD, more common in high functioning populations. So it should definitely be treated if they're intellectually capable people, because they suffer from this impairment from ADHD more than low functioning population. And we did an adult study recently just to disprove this myth, that the ADHD treatments were equally effective in high functioning autism adult folks as we typically say. So don't shy away from the treatment for the ADHD with stimulant medications. They are very effective. But for autism per se, the outcome could be variable, but in the end, it helps intellectually a lot.
Hey, thanks, Joshi. I also, before there are several other questions for my colleagues, both Dr. Pedrelli and Dr. Roffman, but I just, since you're talking about ASD, I have to stop and just tell you how moved Connie went to, we don't see her on her video screen, but I just want to mention how moving your talk was and your comments, and in my mind really speaks to, Maurizio made this comment, there you are, Connie, Maurizio made this comment that, at MGH, we don't give up, and we get referred really challenging cases. And what impressed me about your story was, and you can even, I'm curious if you have any thoughts about it, which was that, it was really the partnership between Dr. Joshi and your family and your daughter, and sort of staying on board, whether he was answering his cell phone or administering medicine. It was he was willing to sort of sign on with you and your daughter over the long haul, even during some very challenging situations. Because I know that invariably it wasn't always just moving forward. There were some times where you a couple of step backwards too. I didn't know. I was sort of very curious about the staying power of that partnership and how important that was.
We felt completely supported, and there were the darkest of dark times. You heard the sink story. That's just one of many. When we first moved up here, we moved to Massachusetts to be near Dr. Joshi because we really felt like the light at the end of the tunnel was becoming dim as she was at 18 years old. And we never felt unsupported by Mass General, but we knew the window was closing on Christine and how do we get her to be a functioning adult in society. And we never had reason to feel like we were in this alone. A sync got pulled out, and let's just say before we met Dr. Joshi, we had been to 3 different hospitals in the New York metro area. We had so many different diagnoses. One of them was Christine had a fatally shrinking cerebellum after an MRI for migraines. We didn't know where we were headed, but we were willing to take the risk, and we were completely partnered by Dr. Joshi. Christine has had his cell phone and his email since she's been 6. When COVID hit and Christine had just transitioned from residential student to day student 2 days prior, I expected the ceiling to fall. And it didn't. And she did go through a blip. But she picked up her phone and she called Joshi on her own. And I sat in awe of who this young woman had become, like the shining star after you pull all the layers of drama and trauma and misjudgment through the years off. And here was her knight in shining armor. And I say that, and it sounds extreme, but I have to tell you, my kid loves him. He is family, and we may be crossing professional boundaries on that, but how can you not love a person who has never abandoned you in your darkest hour and has celebrated with tears your successes, whether they're baby steps or monumental?
Connie, thank you so much for sharing your story. And all I have to say is I'm a professor of psychiatry at Harvard Medical School, and I don't have Joshi's cell phone number. So I'm very happy for you and for Christine and for your family. Paola, there's a really terrific question as you were talking about the various sort of wearables and sort of how much data you collect. Someone actually asked about sort of how you integrate it, and also sort of what's more important. Like, do you go with what your Apple Watch said, or do you go with what another sensor said? And I was actually thinking myself about, do you use big data? How do you come up with sort of what information from the sensor you follow?
So at this time, like, again, we are really focusing on determining model that can estimate depression. And so we get all the data that we can. So we're not necessarily discriminating, like the more data, the better it is. So it's definitely big data. And that's why we're using machine learning within like AI. And we had something like 400 features that we are including in our model. So definitely like a lot of features. So our next step, again, like our pilot was a small pilot. So we couldn't really determine what was more powerful. And so at this point, our next grant, one of our aim is really to identify, do we need both a watch and a mobile phone? Like, how many sensors do we need? Like, how many information? What's going to be more critical? And so this is definitely the next step that we are looking into. Like, we don't know yet.
So, and Paolo, a follow-up to that question, and also this dovetails with Roy's remarks. You know, when you hear about innovative science, there's sort of the spirit of innovation. There are the studies that you know, take that, try to study very interesting questions. But two people asked about sort of the time to roll out in a way of AI. And Roy, also, I'll ask after Paolo finishes your thoughts about that. When you look at sort of AI big data, that will sort of, how long till we start getting answers to questions that will really start to respond to the clinical dilemmas that you heard about, for example, with Christine or any of the patients that we take care of clinically?
I mean, unfortunately, I have to say it depends on the question. So I think it's going to take a lot of time before we are able to give Fitbit or Apple Watch to everybody who goes through the PCP. And that's, like, I have to be honest with that. I do think that I see my role as contributing to research. And so you have academia advancing this program, and you have places like Apple's and Microsoft, they're also advancing that research. And so I think probably the research is going to be integrated, and we're going to come up with a great model between academia and industry. I am pretty optimistic that something is very exciting is going to happen soon. Like, I'm thinking years, definitely not next month, but I think in a few years we'll be able to provide some very helpful information that could actually be used in clinical care. But that is like one of the reasons why I'm doing this study, and I'm looking both at a wearable and the mobile, because wearable can be expensive. So if all we need to do is to just put something on a phone, that would be fantastic. I don't think it's possible. Probably will need a wearable as well. But that's, again, we need to look in science. Science really needs to lead and answer that question. But definitely a number of years before we're going to be able to actionable, like this going to be actionable.
And Roy, do you think that you know, using AI in the context of, you know, now that at MGH, for example, and just across America, the electronic medical record and the ability to sort of farm big data in EHR. Are you optimistic at all about being able to answer the questions about predicting who may be at risk? So where do you come down on that?
So here's the thing. I mean, the future is now, in the sense that we could do it tomorrow. We could have done it 5 years ago. Models are good enough. We can do better, as well or better than psychiatrists in making these predictions. The challenge is that the way I like to frame it is, I gave a talk a few years ago at the Broad, and someone looked at me and said, well, is this a problem of science or a problem of engineering? This is a problem of engineering, in the sense that it's really just building the systems that compute over the health record and provide it to clinicians. And the sort of uncomfortable truth is that's a question of money, right? So it's a question of who's going to pay to develop those tools, or really to deploy those tools. And unfortunately, NIH does not tend to fund that kind of work. The hospital has its hands full with other kinds of investments right now. And so I think a lot of this, frankly, is going to come from startups and the sort of for-profit world. And frankly, that's why when we build our models, we put them up on GitHub or up on the web and hope that that other people will take them and deploy them. So I'm optimistic in the sense that they're good enough to use now, but I'm pessimistic because it's not clear who should pay for it.
Hey, thanks, Roy. Josh, a question for you. So if I understand this question that got sent in sort of correctly, if I understand the question correctly, so you describe sort of a longitudinal models. You're going to have this cohort, you're going to follow them for a long time. But the question was really about the implications of the data that you're collecting around COVID, and is there sort of, how soon will you have some information about the impact of this extraordinary once-in-a-lifetime stressor on some of the outcomes that you're looking at in B4?
That's a great question. And the answers can't come soon enough, of course, given the severity of the situation. This is why it's so important to be working with a terrific team. So this, the B4 project really builds on collaborations across psychiatry, obstetrics and gynecology, pediatrics, medicine. And the people who are the experts at answering that question are in pediatrics. So we are working with several individuals in pediatrics right now to ask this question: what is the earliest time point after birth we might expect to see something that gives us signal? And going into this as a psychiatrist and not a child psychiatrist, I would not have the first clue about where to look. And it turns out that in these initial conversations, which I'm very glad we're having, the answer is pretty soon. You can begin to see, even as early as 3-4 months, sometimes a little bit earlier than that, the first signs. They're very nonspecific in terms of what will happen down the road, but that's why it's so important to really have a longitudinal approach, so that we can say when the child is 1 or 2 and is in that early age when, say, if something like an autism spectrum illness were going to emerge, that's about the time when it would fully emerge. We can then go back and say, okay, what happened at 2 or 3 months for this child, and their behaviors and their developmental milestones and their eye contact and their smiling and their laughing and all of those things that we can measure that may have some prediction on what happens later on, as early as 1 or 2, when the first kind of clinically meaningful psychopathology can begin to hit. And of course, with things like ADHD that present later in childhood and all the way out to late teens, early 20s, which is where you have a big peak for schizophrenia, depression, bipolar disorder. It's going to take that long, unfortunately, to get those kinds of answers. But in the meantime, I think as Paola said, big data is our friend. And we want to pull out whatever we can to give us some insight as soon as we can about what's going on.
Hey, thank you, Josh. There's actually a question on the fly for the chief. Dear Dr. Fava, these presentations were about innovations in research. I heard you speak in Palm Beach about patients who don't get better, or treatment treatment-resistant depression. Are you optimistic about innovations for treatment-resistant depression? Because I have family members who have been on, I think, 10 to 15 medications. And it dovetails a little bit with my question about Roy about, are we getting closer to being able to match patients with antidepressants? And so if we're talking about innovation, Maurizio, for patients who've had multiple trials, are you excited about what's coming down the line?
Oh, absolutely. I think that, we have been waiting for a long time for medications that were not always using the same neurotransmitters or rounding up the usual suspects. So we have now treatments like esketamine and treatments like the Brexanol for depression that are really novel. They're targeting novel brain circuitries, novel neurotransmitter systems. And I think we're going to see really a resurgence of psychopharmacology in the next 5 to 10 years with new compounds that will really be revolutionary. I think that the work that Roy is doing is actually creating the basis. His lab is identifying new molecular targets. And that means that we can take Roy's discoveries, put them into, develop compounds that reach those targets, and then try to develop them as new therapies. So I think that we have a little bit, we've had a couple of decades of kind of resting on the laurels of SSRIs, successes, and so forth, but fundamentally not having breakthroughs. And now we're going to see really something amazing. So I'm very optimistic, as you can imagine.
Just as a follow-up, as we are all in the middle of this pandemic and waiting for a vaccine and seeing sort of the evolution of very novel partnerships between parties who are working together in a way, government, private sector, industry. Are you optimistic about similar models being used to take research in, for example, the treatment of psychiatric disorders and specifically in your area, depression, forward?
No, absolutely. I think that, in this tragic pandemic, one of the things that we've seen is that people realize this is really critical, that all hands on deck, and let's get, industry and academia working together. And so, for example, we at Mass General with Mass Pioneer, we're developing a vaccine for COVID-19 in collaboration with Novartis. And Beth Israel Deaconess is developing a vaccine, Pfizer, and so forth. So suddenly, instead of saying, oh my God, you shouldn't work with the industry, you shouldn't do this, you shouldn't do that. Now, finally, people realize we all share the same goal of developing new treatments. How about if we work together? And let's try to be less bureaucratic, less obstructionistic. And so we're seeing that now translating into neuroscience and developing new therapies, which is a great thing.
Well, if there's anything that we've learned over the last 12 weeks or so, is that it really does take a village. And as we sort of kiss the end of our time that we've allotted for this seminar, I want to thank my colleagues for the richness of the science that they do, and also their commitment to patients, because at MGH, no one calls themselves an expert unless they see patients. And I also mostly want to thank the folks who signed in today. I hope that you found it helpful and illuminating, and most importantly, during these times, please stay safe and stay healthy. And again, thank you for joining us this afternoon. Have a great afternoon. Bye now.
Bye-bye.
Bye-bye. Thank you.